Today we will talk about the pediatric septic shock management. If you are a pharmacist working in pediatric population, especially in the PICU unit, I think this short video will be very important to you. Before, since 2022, there is some criteria to detect or identify the shock to take the early management stages before the patient got shock. Now in 2026 there is some update, so we will go through it in brief. The child is in septic shock in front of you, and here is the first thing that will save their life, because it is the thing most people get wrong. In a child, blood pressure is the last thing to fall. In an adult population in shock, blood pressure drops early and you see it on the monitor, but the child doesn't. Why? Because the child compensates. They clamp down, they keep their pressure looks normal right up until the moment they crash. But once they crash in minutes. So we don't wait for the number, we resuscitate on perfusion, and there is some criteria to identify the improvement of the perfusion, and these tools, it is the same tools used to detect the pediatric shock in pediatric, like the capillary refill, the pulses, the mental status, and urine output, lactate trend. But if you wait for the blood pressure to drop, you have already waited too long. This is the 2026 edition, so as we go, I will flag every place. The guidelines have moved since 2022. As you can see here, the update in 2026, the Phoenix tool to clarify and detect the early stage of sepsis or septic shock. Before, since 2022, they expect shock in pediatric through criteria called systemic inflammatory response syndrome. And this criteria, according to the change in some tools like temperature, if it is more than 38.5, like blood pressure, heart rate. But now in 2026, there is some change, because the definition itself changes. The old SIRS criteria, it's gone. Since 2024, the international standard is the Phoenix sepsis score, and the shift is conceptual. Sepsis is now defined by organ dysfunction, not inflammation. It is a score of 2 or more across 4 systems: respiratory, cardiovascular, coagulation, and neurologic. In septic shock, it is sepsis plus cardiovascular, especially point, meaning severe hypotension for age, as we said, because in pediatric, the drop in blood pressure, it is a late sign. And lactate above 5, or the need for a vasoactive drug like epinephrine or norepinephrine. And the term severe sepsis retired because SIRS was dropped because it simply wasn't good at predicting who would deteriorate. So the definition modernized, but here is the reassuring part. The resuscitation cascade I am about to walk you through is still the score. The 2026 Surviving Sepsis campaign refined it, and I will mark each change. Recognize early, get access. So The sequence step on oxygen and access. Once you receive a pediatric patient in septic shock condition in your PICU unit, the first step you need to do or confirm the oxygenation. So oxygen first by non-invasive means. If it is not possible, you have to shift the patient to mechanical ventilation. And recognize the shock on perfusion through rising lactate, the metabolic acidosis, the falling urine output, the prolonged capillary refill time. Give oxygen first. And here is where people forget under pressure in a choked child. Intraosseous access is completely legitimate first line. Maybe you can't get IV access, so guideline highlights that intraosseous access can be a suitable alternative. So don't burn 10 minutes hunting for a vein while the child deteriorates. Drill the bone, get your access, and move straight to fluids. Balanced crystalloid. As we agree, if I will start a fluid, which fluid? In adult population, the normal saline can be an option in shock management. But actually, the latest guideline, even in adults, they preferred balanced crystalloid, like plasmalite or lactate ringer, to avoid the risk of hyperchloremic acidosis from the normal saline, especially if it is given on fast infusion or large amount. So better to go for balanced crystalloid, not normal saline. What is the rate? Give it as 10 to 20, and better to go for 20 directly ml per kg as bolus. And here is one critical point. I think many healthcare practitioners, either physicians or pharmacists, can drop it under the stress of the case that they are giving the mini bolus without reassess the fluid response between each bolus. So you need to reassess after every single one to confirm that there is no volume overload. So you will give first bolus, then assess the patient for fluid response. There is many tools. I will not go through it now, not to make it the lecture long, but you can review it and to confirm that there is fluid response. What is the maximum bolus I can give? If the patient is not in ICU unit, in the normal ward unit, you can go for 40 ml per kg, but if the patient is in PICU unit, you can go for 60. Now, the strong 2026 update, and this one reverse old instinct. If you are somewhere without intensive care and the child is not hypotensive, you give no bolus at all. You start maintenance fluid. This is also one of the updates. This is one of the very few high certainty recommendations in the entire 2026 guideline, because in that setting, aggressive bolus did harm. Read that twice. No ICU, no hypotensive, no bolus. Now, as a revision, we started with oxygen. We found the axis, either IV or interosseous. Then we start with the fluid. Third step fluid. Then the fourth step, the antibiotic. Of course, if you have septic shock, it means that I have general infection, sepsis in the bloodstream. So I need broad spectrum antibiotic fast. And this is the one both exams and real life punish you for missing antibiotic. If you apply for exam in American Board of Pediatric, this is one of the critical points you have to focus on it, because broad spectrum within 1 hour it must be off after recognizing the septic shock. But before giving the antibiotic, of course, I need to draw blood culture first, as long as it doesn't meaningfully delay the drug. The drug still comes first if you have to choose. In 2026 update, it is probable sepsis without a shock. You have a little more room. You have 3 hours. If it is sepsis without cardiovascular dysfunction, then I have window of 3 hours, not 1 hour. Also, another new suggestion, consider an infectious disease consult for a documented bloodstream infection. One more, if you suspect toxic shock syndrome, add clindamycin to shut down the toxin production. Now, my fifth stage, that vasoactive. If the patient fluid resistant shock, I give my full volume. But here, one clinical trip, that don't wait until you give the patient the full IV fluid if there is no response. After 1 or 2 bolus, if the patient not respond to you and the perfusion not improved, you have to think about the vasoactive agent. So the vasoactive agent either to be epinephrine or norepinephrine. This is the first line. And also in 2026 update, the guideline is explicit. It will not rank one over the other. They are co-equal, pick based on your patient, not a hierarchy. And take care that dopamine has been displaced. It's no longer your first reach, but I can use in case, and this is rarely you will find it, you will not find like epinephrine or norepinephrine as a alternative. Something to solve the situation until the epinephrine or norepinephrine be available. 2 more 2026 changes. First, start the pressor through a peripheral line. Don't let dying child wait for a central line to go in. Second, when the catecholamine dose keeps climbing, add vasopressor rather than just pushing the epinephrine higher. If you give the patient like epinephrine or norepinephrine and there is no the uh, expected response, you can add other catecholamine like vasopressin, better than increasing the dose of epinephrine. As we know that also here there is one clinical trip that epinephrine can increase the lactate. So if the patient other tools which we mentioned early, like urine outputs, like capillary refill time, is like blood pressure, like heart rate improved, and the lactate not improved, and the patient on epinephrine, take care that epinephrine increasing the lactate. So don't consider this and try to adjust the dose of epinephrine. Also, now unlearn an old reflex. We used to give hydrocortisone almost automatically in catecholamine-refractory shock, but in 2026, guideline pulled back. If fluids and pressure have restored stability, it suggests against routine hydrocortisone. Reserve it for the child with genuine adrenal insufficiency. Steroids are now a targeted decision, not a reflex. Through all of this, also, you need to keep glucose 180 or less and avoid hypoglycemia. This is a point which we highlighted before. Epinephrine itself increases glucose and lactate. So don't panic when lactate increase while the patient on epinephrine. It is a direct metabolic effect of the drug, so that rising lactate may be the medication, not the disease. Don't chase it blindly into another liter of fluid and a higher pressure dose. Read the whole patient, the perfusion, the pressure, the urine output before you react to a single number. So tomorrow on your shift, Phoenix defines it now. Score of 2 is sepsis, plus cardiovascular point in shock, perfusion over pressure, blood pressure falls last, balanced fluid, reassess every bolus, and no bolus in the non-ICU child who isn't hypotensive. Antibiotic is in 1 hour, culture first, epinephrine or norepinephrine co-equal, preferably dopamine pinched, steroid only for adrenal insufficiency, and don't let the epinephrines on lactate fool you. That's the 2026 Septic Shock Cascade. This is what I do here. I take what the 2022 board taught, show you exactly what 2026 change it and turn it into something you can use as a bedside. I am working through the entire pediatric pharmacy board, the PCBBS critical care syllabus, so you can follow Dr. Pharma Academy and study it with me.